sent him a message. He'll be joining at 4 o'clock, Professor.
Oh, okay. Okay.
Okay.
So thank you very much. Thank you.
Yes. So before we start, our chairperson today, Professor Ali Aziz Sultan, may I request opening remark about today's topic and about the participants today. Thank you, Professor.
Thank you, my younger brother. Thank you, Sachin, for the invitation. Professor Kato, thank you for your kind invitation. Thank you for your constant generosity, and thank you for the spirit of this beautiful conference. This conference, just look around what it represents, you know, and what it represents, what a beautiful side of neurosurgery. We have India, Ukraine, the US, Afghanistan, Myanmar, China, Japan, people from all over the world talking, sharing ideas, learning from one another. It's really the spirit of how we should go forward in the world. It's leadership through neurosurgery and people like Professor Kato that see beyond you know, themselves. I think the spirit of the lectures and the lecturers that are speaking today are the same. You know, Professor and the rest of the panel, we were talking today about open surgery versus endovascular, you know, large skull-based complex skull surgery versus keyhole approaches, these sort of controversies of you against us, were in the spirit of this conference. The way that Giuseppe Lonzino does things, where combines the art of the mastery of traditional neurosurgery with the most advanced new techniques. And Dr. Miyachi and Dr. Zafeng, in their own right, pushing neurosurgical excellence forward, whether it's keyhole approaches or complex techniques towards endovascular approaches. As neurosurgeons, we often follow exactly what this conference is about. We're usually the leaders in pushing the frontiers and embracing and constantly learning and expanding for not only the good of our patients, but the good of medicine and the good of humanity. We're now reaching places like Myanmar and Afghanistan, and you open these doors to places that you didn't know about before, and you see how special the mind of the neurosurgeon and the heart of the neurosurgeon are in these places. The most beautiful things I've seen in some of these places like Afghanistan and Professor Pirzad and so forth. So I'm very excited and honored to start this conference and proceed. Thank you so much.
Thank you very much, Professor. So we'll start with our first speaker. Allow me to introduce our first speaker today, Professor Giuseppe Lonzino. He's completed his neurosurgical training at the University of Virginia in Charlottesville in Virginia. In addition to that, he has completed his subspecialized training in endovascular neurosurgery at State University of New York at Buffalo, and cerebrovascular and skull-based surgery fellowship at Barrow Neurosurgical Institute in Phoenix. At present, he is professor of neurosurgery at Mayo Clinic, Rochester, Minnesota. His special interests are brain aneurysm, brain and spinal arteriovenous malformation, dural fistulas, carotid stenosis, and cavernous malformation. He has authored and co-authored more than 600 peer-reviewed publications, and he is the author of 4 neurosurgical textbooks. May I request Professor Lonzino to share his screen and start his presentation, please.
Thank you very much. Let me see if I can share here my screen.
Yes, perfect. We can see it, Professor.
You can see my screen?
Yes.
Okay. And you can see my slides, correct?
Yeah, but it's in the
Yes, seeing the
slide mode. You
next
need to go to
slide.
presentation mode.
Sorry about this.
It's the same.
I'm sorry, it's one of those systems with two screens, and
I think the one in the center. Yeah, the one in the center.
it's still in presentation mode, correct?
Yes.
Mm.
Yeah.
I'm sorry about this. That's
And just click the flask symbol on the right bottom, right side, on the PowerPoint. Still the presentation.
Okay, I'll try to help you. Can you click on those three dots there at the bottom? Swipe the presenter view and slide view. That maybe that.
okay here.
Yeah, hide the presenter. Yeah, yeah. Click on that.
Now, can you see, or
We're not able to see.
there is this system with I can see the correct I have two screens, and I can see the correct presentation on one screen and then the presentation mode on the other.
Sachin, we can see the slide, so I think it's
Yeah,
fine.
I think we can continue like
Oh,
this.
We can,
It's fine.
okay.
It's
It
very
just
clearly.
So,
yes.
sorry about this. I had to. So the topic today is dural AV fistula, and we really have gone a long way since this seminal publication from my institution by Dr. Sant and Dr. Pipgras in 1983, where in Journal of Neurosurgery, they reported the treatment of patients, surgical treatment of patients with transverse sigmoid sinus dural AV fistula. And hard to believe that it was only 40 years ago, but they reported in that series some cases where unfortunately the patient died during the surgery because of blood loss just during the craniotomy. So nowadays we have a lot of possible options, and I think that nowhere more than in the treatment of dural AV fistulas, we are able to really choose and combine the various options that we have and really be able to provide a truly individualized treatment. When we think about dural AV fistula and we think about the factors that affect our choice of treatment options, definitely the presence and the type of symptoms, the angioarchitecture of the lesion, and the location. So the choice of the therapeutic modality is, of course, guided by the safety, the efficacy of the therapeutic modality, and how invasive that particular treatment modality is. Now, I will show a few case examples, and here and there, I will share few pitfalls and pearls that we have learned during the treatment of now more than 200 of these lesions. So here is a patient that presents with hemorrhage, 41-year-old, decreased sudden onset of headache, decreased level of consciousness, and eventually coma. And you can see here from the CT angiogram, you can see a varix along the petrous ridge, and then a draining vein which travels superiorly. You can see here the draining vein. Here another varix, probably you can see the varix in relation with the hemorrhage, so probably the site of the hemorrhage. So this draining vein, which eventually drains the transverse sinus. And here is the angiography with arterial feeder to the fistula from the internal carotid artery, and you can see that the fistula is along the insertion of the tentorium on the petrous ridge, and then there is a retrograde venous drainage with multiple varices. The fistula also is fed. You can see here there is some fade filling through the petrous branch of the middle meningeal artery. And then what are the consideration in this case? So we have a large posterior fossa hemorrhage, vessels that are not easy to catheterize. When I say not easy to catheterize, I mean it's not easy to achieve a distal enough microcatheter position because of the small caliber and the tortuosity of these vessels. And the only potentially accessible vessel in this case for an endovascular point of view is the petrosal branch of the middle meningeal artery, which also has branches to the seventh nerve. So in this case, we elected for surgery, which the other thing about these fistulas that we will discuss is that for the fistulas that have exclusive retrograde cortical venous drainage, once you are able to decodify the anatomy of the fistula, the surgical treatment, it's fairly straightforward. That's one concept. Another concept is that once you identify the location of the fistula, these fistulas, they have a surprisingly consistent pattern of venous drainage and morphology. And here you can see the post-op CTA with the clip at the origin of the arterialized veins. Here, one small pearl is that in dural AV fistulas, unlike, for example, intracranial annulus, the site of rupture, it's often distal from the actual point of fistulization. In this case, we saw that the fistula is a petrosal or lateral tentorial fistula, but the site of rupture in this particular case was probably at the level of this varix, so far away from the actual point of fistulization. And here again, you can see here the actual point of fistulization. This is can be characterized or classified as a lateral tentorial dural AV fistula. And again, the point of fistula is at the site of, fairly consistent at the site of the petrosal system. And then there is a retrograde venous drainage. In this case, you can see with the eventual emptying into the transverse, the transverse straight and the straight sinus. So these are again a lateral tentorial dural AV fistulas, not that uncommon. They have exclusive retrograde venous drainage. So those are those dural fistulas that are dangerous in terms of their angio architecture. Typically involve the superior petrosal system. And this is another case, 69-year-old presented with imbalance and dizziness for 1 year and double vision for about 6 months. You can see on the MRI, you get the impression when you see these large vessels that are not confluent into a nidus structure on the MRI, then you can suspect the presence. You can see these dilated vessels in different areas, not in a nidus structure. You can suspect the presence of a dural AV fistula. And here again, you can make the diagnosis just on the plain T2 MRI. You can see the venous varix and the arterialized vein emerging from the dura at the level of the tentorial insertion. So another lateral tentorial dural AV fistula. And this is the angiogram. This is a left external carotid artery injection. You can see, as I said before, sometimes on the angiograms, these fistulas, even the ones with the exclusive retrograde cortical venous drainage, they look quite intimidating, quite a complex angioarchitecture. But then when you can decodify then the treatment, at least for the ones with the exclusive retrograde cortical venous drainage, the treatment becomes fairly straightforward. In the recent years with angiograms, imaging has improved, and here we can do a angiography-based fine cut CT angiogram. And you can see here that the point of fistula with the large arterialized draining vein emerging from the dura at the level of the tentorial insertion. And you can, again, here you can see this patient was referred to us after she underwent attempted embolization elsewhere, but because of the tortuosity of these feeders, they were unable to achieve a distal enough position of the microcatheter to be able to effectively embolize the fistula. In this case, as I said, because of the failed prior embolization, we elected for surgical treatment, and you can see that this is a pretty straightforward retrosigmoid craniotomy. And you can see here with ICG fluorescent and the typical location of the arterialized vein at the site of the petrosal system. And you can see that there are all these, the arterialized draining vein emerging from the dura, with all the small arterial feeders converging at the level of the dura into this into the draining vein. And you can see as I said, once you codify the fistula, the treatment is pretty straightforward and consists of clip ligation or interrupture, coagulation, and division of the draining vein at the site of where the arterialized vein emerges from the dura. Here you can see the immediate post-op. This here was read as a small hemorrhage, but this is not a hemorrhage. This is the thrombus inside the dilated the varix, proximal varix of the draining vein. And you can see the post-operative MRI with you can see on the left panel the pre, on the right panel the post treatment MRI, which was done just a few weeks later. And you can see how there has been a remodeling already of those dilated and tortuous arterialized veins. Here on the right panel, you see the thrombosed venous varix. Now, this lateral tentorial dural AV fistula, as I said before, and this is common to dural AV fistula, same thing for retimoidal dural AV fistula or medial tentorial dural AV fistula. They share, after you see a few, you realize that they share a lot of commonalities. They might look different on the angiogram. Once you understand the fistula, once you decompose in the simple components, the treatment becomes straightforward. This is another video of another lateral tentorial dural AV fistula, just to stress the fact of the commonalities. And here you can see on the CT angiogram the point where the arterialized vein, and again, retrosigmoid craniotomy, right at the junction of the petrous ridge with the tentorium. You see the large arterialized vein emerging from the dura and all the small arterial vessel converging into it. And once I understand that the anatomy, the treatment is pretty straightforward. Here's the pre and post after a clip ligation of the fistula. This is another situation where it's again a fistula based on the tentorium, but the hemorrhage was, in this particular patient, was supratentorial, small posterior temporal hemorrhage. And you can see here on the AP this site of fistula. You can make the slope of the tentorium, and here on the right you see the plain film after with the onyx cast. So in this case, because we were able to catheterize distally branches of the milomeningeal artery, we were able to get so close to the point of fistula. You can see here, this is our micro catheter, and this is the transition from the artery to the supratentorial vein. And you can see that we were able to reach such a distal position that embolization was fairly straightforward and effective in obliterating this small fistula. This is another example where, as I said before, when there is supply from the petrosal branch of the middle-meningeal artery, and that's the best and the only available vessel, we tend to be a little bit shy with embolization. But of course, there are exceptions, like in this patient presented with facial pain and pulsatile bruit. You can see again the typical appearance of these fistulas, lateral tentorial fistula with the arterialized vein emerging from the petrous ridge. And here you can see the fistula. But in this case, we were able to, through the middle meningeal, to really achieve a position almost inside the draining vein. And we felt we were able to, you can see, to obtain an onyx cast with the really minimal or no reflux and be able to effectively treat this fistula with embolization, despite we were through the petrosal branch of the middle meningeal artery. Now, another pearl, and I think this can open a discussion about the importance and the role of the venous system, of the intracranial venous system, and some pathologies that probably have not been defined yet, is that dural AV fistula really can present, of course, they can present with hemorrhage, but otherwise they can present with really any neurological symptom or signs or constellations or combinations or various symptoms and signs. And that because while the arterial system, it's fairly predictable in its distribution, the venous compartment, there is a lot of variability and lot degree of involvement of not only one single brain compartment, but often multiple brain compartments. And I think that is this observation to see the variety of symptoms with which these patients can present has really got me very interested in the potential role of the venous system in the many pathologies that, as I said, probably have not even been described yet. This is, for example, is a 52-year-old presented with progressive cognitive impairment. And you can see that it's almost like a dementia-like pattern. And this can be observed, especially with the fistulas involving you see there is arterialization here of the superior sagittal sinus. And therefore, this patient suffer from impaired global venous return that clinically can manifest as a form of dementia. And this particular fistula, this is a sphenoparietal fistula. Again, once I will show you the treatment, again, this type of fistula summarize the fact that many of these fistulas that have exclusive retrograde venous drainage can be quite intimidating on the angiogram, but then once you understand that they are relatively simple and the treatment is pretty straightforward. Here, what we are looking at, this is a simple terional craniotomy. The dura, which is here, has been open, and you can see that there are some charcoal large dural feeders that have been partially coagulated. And this is the brain, and this is the sylvian fissure. So this is nothing but an arterialized vein emerging from the dura at the level of the sphenoparietal, going into the sphenoparietal sinus. And you can see that once you just open the dura, the treatment again is pretty straightforward and consists in clip ligation of that large, hard, and arterialized vein. And here you can see the pre-op and the post-op with improvement of cognitive decline. So dural fistulas are a rare but potentially treatable cause of cognitive decline and even dementia-like picture in young individuals. We discussed this, that again, these fistulas with exclusive retrograde cortical venous drainage, they may appear quite complex on the angiography, but once you understand the angioarchitecture and the anatomy, the treatment can be quite pretty straightforward. And the treatment, the key for occlusion and cure of these fistulas, as we have learned over the years, is that you must occlude the proximal portion of the draining vein as it emerges from the dura. That's the reason why the endovascular treatment occasionally can fail, is that unless you completely obliterate that proximal draining vein, the treatment is likely bound to fail. I think we can skip this. So sometimes, though, we deal with fistulas that are so complex where a definitive cure might not be possible, and occasionally palliation of symptoms can be a reasonable goal of treatment. This, for example, is a 42-year-old with Down syndrome that presented with the progressive gait impairment. You can see that there are T2 changes at the craniocervical junction in the upper cervical and upper cervical cord and in the medulla. And this patient had a very complex pattern of, we couldn't really tell if it was a single fistula or multiple fistulas. Look just at the external carotid artery as the diameter. Some of these branches that is larger than the internal carotid artery. And what we did in this case, you can see very aggressive embolization of the main point of fistula in the superior sagittal sinus, along with the proximal occlusion of some of the largest dural feeders. And you can see that we were able to palliate the symptoms. This is the 1-year follow-up. Look, there is a resolution of the T2 changes, being this a patient with Down syndrome. Before we embraced into treatment of the fistula, we made sure that the changes were not related to C1-2 instability in this particular patient. But you can see here that after partial treatment of that fistula, there was a resolution of her symptoms and improvement of the T2 changes. And interestingly enough, decreased compression. Look how much more CSF space is visible 1 year after treatment. Particular type of fistula are the anterior retimoidal dural AV fistula. Like the lateral tentorial dural AV fistulas, they are fairly consistent and they share a lot of commonalities. They tend to be fairly similar. despite the angiographic appearance can be quite heterogeneous. This 34-year-old presented with headache and early dementia-like symptoms. You can see that on the T2 there is a large vein that seems to emerge from the ethmoidal plate, and you can see on the angiogram the typical appearance. Main feeding to these fistulas is from ethmoidal branches, dural branches of the ophthalmic artery. And this is one of the reasons why we still prefer quite often to do surgery for these fistulas. You can see here the pre and the post-op. Pre, there was early opacification and arterialization of the superior sagittal sinus that you don't see on the post-op. And as I said, you can see this is a straightforward medial frontal craniotomy, and you can see here the large veins. You can see here at the level of the ethmoidal plate and the crista galli, all the dural feeders converge into a large arterialized vein. And here is the ICG fluorescent. And again, once you decodify this fistula, the treatment is fairly straightforward and consists in occlusion of the proximal portion of the draining vein. We discussed about this concept before, that the dural fistulas that I've seen causing dementia-like symptoms are either the ones that cause arterialization of the superior sagittal sinus, like the anterior ethmoidal dural AV fistula, of the sphenoparietal fistulas that we saw before. The other type of fistula that has been reported to cause a dementia-like picture are some of the tentorial, usually medial tentorial dural AV fistula, which can interfere with the drainage of both thalami and can cause a dementia-like picture from impairment of venous drainage from usually bilateral thalami. Now, when we deal with anterior ethmoidal dural AV fistula, interesting and important pair is to consider that occasionally some of these fistulas might be, often they have bilateral feeders, but occasionally these fistulas can be truly bilateral. And the way to tell is to analyze the venous drainage from the left and the right internal and external carotid injections, and make sure that if the drainage is the same, or on the AP, carefully evaluate to make sure that the fistulas are not, it's not a single fistula, but there are bilateral fistulas, because they've been reported. And okay, if you don't recognize and you do surgery, if you don't treat both sides, you might need to go back and treat the other side. Now, as I said, that this anterior tentorial, anterior ethmoidal dural AV fistula, because often they have a prominent feeding from branches of the ophthalmic artery, we prefer surgical treatment. But of course, there are exceptions, like this 81-year-old. You can see here, this is anterior ethmoidal, typical anterior ethmoidal dural AV fistula. But in this patient, there is a prominent supply from middlemeningeal artery and eventually falcine artery. And you can see this is the falcine artery that goes to the fistula. And then here, this is the draining vein. But nowadays, with modern catheterizations, we were actually able to get through the middlemeningeal all the way close to the point of fistulization. You can see here. And so that we were able to embolize this fistula from an arterial. Here you can see the selective injection. Our microcatheter, it's very close to the point of fistulization. And here you can see the onyx cast in this patient, 81-year-old with an incidental finding. We were able to do it with without open surgery. Now, this is another situation that occasionally you might find. This is a patient who presents with progressive headache, refractory nausea and vomiting. And there is edema and flare and T2 changes involving the brainstem. Often these patients, at first, the diagnosis is a possible neoplasm or inflammatory condition. But when you see this pattern of T2 changes in the brainstem, always suspect a fistula, like in this case. This was a craniocervical junction dural AV fistula. You can see here the external carotid artery and the ascending, particularly the ascending pharyngeal supply. And you can see how there is venous drainage from the coronal plexus of the upper cervical cord and the lower brainstem. And in this particular case, again, when the fistula is close to the brainstem, we prefer to do surgery. And these craniocervical junction fistulas, they also have a this is a far lateral approach. You can see the vertebral artery, the 11 cranial nerves going from cervical to the brainstem. And here you can see right at the level of C1, you can see this arterialized vein that you can follow along the posterior margin of the medulla and the upper cervical cord. You can see here is the arterialized vein emerging from the dura. These are some rootlets of C1. And here you can see that, again, treatment is pretty straightforward. And again, these fistulas, they have certain patterns. The craniocervical junction types, the arterialized vein emerges from the dura right adjacent to the point where the vertebral artery pierces the dura. So again, once you understand and identify, the treatment is pretty straightforward. And here you can see the post, but more importantly, compare the pre-op with the 6 weeks follow-up. These problems are very gratifying because you can see a patient that was miserable because of his symptoms comes back after only 6 weeks and as a normal neurological function. So for the craniocervical junction, if they drain superiorly, they can present with hemorrhage. But if they drain with, if they have exclusive inferior drainage, like this particular patient, then they present with myelopathy or with bulbar symptoms. Before I conclude, I like to briefly touch upon the most common type of fistula, that is the transverse sigmoid sinus junction. This is a 49-year-old with disabling bruit And you can see the typical pattern of fistula, and there is no retrograde cortical venous drainage. So for this type of fistula now for more than 20 years, we have used a fairly straightforward and almost a unique treatment approach, where what we do in this particular patient, elderly patient with the disabling bruit, the number one goal of treatment is to improve the symptoms. So what we do transarterial embolization with the PVA particles. And here the caveat is that you want to use particles that have a diameter greater than 150 microns. So there is no danger that the particles might go through dangerous anastomosis. And once we are done with the transarterial PVA embolization, and the patient's symptoms almost always improve or resolve, then we proceed with the gamma knife. The gamma knife is very safe because it is basically what you are radiating is the bone. The transverse sigmoid sinus junction is within a sulcus in the skull, so there is minimal or no radiation to the brain. And using this approach that was first reported in 1996, you can see here in this case, we are able to treat very effectively these fistulas with virtually no morbidity and about a 90% chance of complete obliteration within the first year or within the first couple of years. More importantly, you can preserve the patency of the sinus in these patients. So that's again for transverse sigmoid sinus dural AV fistulas. There are different type of possible approaches. Of course, this is not an approach that we would advocate in a patient with dangerous angioarchitecture of the fistula, important retrograde cortical venous drainage, or in somebody who has presented with the hemorrhage. But again, I think that this treatment paradigm that I just described illustrates how nowadays we can really use all the tools that we have available in a very creative way. And more importantly, we can treat the problem, but more importantly, keep the complication rate very, very, very low. And as I said before, it's a fairly straightforward and simple. Radiation is to the sinus. Nowadays, they target the sinus and the fistula just based on MRI. And the embolization is pretty simple. It's a transarterial external carotid artery embolization with the very cheap particles. I'll briefly go through this. Just again, this is to illustrate that these were serious a few years ago, that many of these patients are treated with the combination of therapy. Okay, not every single dural fistula needs a treatment. Observation is a reasonable approach in some of these patients. But what's more important is that you can treat the problem, and the complication rate it's exceedingly low by using all the different tools that we have available, and provide a true individualized patient treatment that keeps in mind the symptoms, location of the fistula, angioarchitecture, and characteristics of the patients. Once again, thank you for the invitation. I apologize for the computer glitch at the last minute. I had to switch to a different device that I had not used before, and I think there were some issues with the dual screening.
Thank you very much, Professor Lonzino. I think we've got two eminent person who's the expert of this particular thing, this particular specialty, endovascular neurosurgery, Professor Shigeru Miyachi and Professor Ali Aziz Sultan. So Professor Ali Aziz Sultan is the chairperson for today's particular webinar. So I request Professor Ali's comment on Professor Lonzino's presentation and his view about dural AV fistulas in the brain. Professor Ali.
Thank you. So Giuseppe, for a number of us, including myself, was sort of the trailblazer of what we were talking about before, neurosurgeons who discovered and pioneered new fields for younger. So when I was a resident, my mentor Harris used to talk about him, and he was one of the first neurosurgeons to start doing endovascular at a very, very high level. But as you see from his demonstrations, the lateral tentorial, the ethmoidal, the craniocervical junction ones, some of the superior sagittal ones, even though you look at them and you say, okay, you know, here's a pathway through an endovascular route, oftentimes it's a craniotomy that we're very, very accustomed to, whether it's the bifrontal for the ethmoidal or the retrosigmoid to the petrosal, and a simple clipping that, as he put, decodes and demystifies and really gets to the base of the lesion through a surgical approach. So he hasn't lost. He didn't, even though he was the first of us to get to endovascular, he never has lost that skill set. And because of that, he can still treat patients effectively. And I have personally seen people catheterize and go for ethmoidal fistulas through an endovascular approach and take on really, really big risks when the solution is simple. Or even in spinal fistulas, you know, going in and trying to do from an endovascular instead of a simple laminectomy and clipping a type 1 dural fistula, going transarterial and then getting a recurrence that's more complex a year or so down the line. So again, a clear demonstration from a pioneer, the importance of retaining those surgical abilities and so forth. Giuseppe, I have a question for you regarding some of the more complex ones that I've run into. So a lot of these that you show look very complex, but you decode and clip. What about these ones that are larger segments, let's say transverse sigmoid, where I've embolized or I've even gone into a pocket through a transvenous route, or even early on, we used to put these covered stents, which I learned from reading articles of a guy from Hopkins named Murphy, these covered stents that sort of crush and then you see it recur distal to where you went. What do you think is the pathophysiology and the solution for these ones that extend large segments, maybe go into the torcula and then kind of recur? How do you think about those, and how do you treat those?
Those are complicated, and the ones that I can recall, some occur in patients that have underlying, typical are the ones of patients with factor V deficiency. So they have some underlying prothrombotic states. I think some of those, what we have done, like the one I show, you go for palliation, or you try to even if you do an incomplete treatment, quite often you are able to improve at least decompress the normal or the compensatory venous drainage system. So patient symptoms can improve. Sometimes these ones, they present with increased intracranial pressure. I must say that with the combination of embolization, aggressive transarterial embolization, sometimes just to bring down the flow overload, followed by gamma knives to different more lengthy segments, we have been able over time to control the symptoms. Some of these fistulas that you start treating, there is a main fistula that probably led to the development of other multiple fistulas. And what we consider a recurrence might not necessarily be a recurrence, might be a pre-existing. So yeah, those can be very complex. And for some, I remember over the years, 2 or 3, I didn't really have either. I didn't feel I had a good solution. And you occasionally come across these massive fistulas. But I would say that the approach that we try to take in those where looks like you cannot really go for one single shot and one single treatment and definite cure, is to try to use the tools we have available, and if we cannot cure the fistula, at least try to improve the symptoms.
Thank you. Professor Miyachi.
Thank you very much, Professor.
Yeah.
Professor Miyachi, may I request your comment?
Yeah. Thank you, Professor Antino. This is a very beautiful operation for the dural fistula. And I have the comment for this discussion. In your last case of the transverse sigmoid sinus dural fistula, we usually embolize transarterially with onyx under the balloon sinus protection. Very big balloon is placed inside the sinus, and so this is a normal sinus. So then we put onyx very slowly from the main feeder, and that's penetrating to all the small branches. So many onyx. Yeah, and that is a good solution. And we have a lot of cases in such a low-grade dural AV fistula. We don't use particles, and so now we use an onyx under valve protection. And so the other comment is, yes, and such a non-sinus type dural AV fistula, as you showed, that is a good indication of the surgical approach. But now we challenge ethmoidal and the tentorial artery using an onyx using a very fine microcatheter and from the ophthalmic artery or the tentorial artery. But as far as the craniocervical junction dural fistula, that is not a good indication for the embolization. So that is the first choice of surgical treatment. Yeah, that is our strategy now. Thank you.
Yeah, no, it's I agree with you in the sense that there are different different possible ways, and again, the key is becoming more and more not how you treat, but to make sure that you choose the plan that is more effective. Because while before many years ago when we started, there were very complex lesions. You get a complication. Well, they are complex lesions. Nowadays, we need to be able to do it without complications. I have a couple of comments. What we have learned, for example, we do use radiosurgery quite liberally for a variety of lesions. But what we have learned that the radiosurgery is definitely effective for the transverse sigmoid sinus, but does not work for the non-sinus type of fistulas. As far as your comment of the balloon-assisted transarterial embolization, I agree, it's a very effective and elegant way to treat some of this transverse sigmoid sinus. In the United States, we have been a little bit delayed in being able to embrace it because we did not have until recently available some of the large balloons. However, I would caution use of onyx in transarterial onyx into distal occipit, because all this, the fistula, it's being a low pressure shunt, encourages the maturation of the pre-existing anastomosis. And with onyx, it starts going into all the smaller feeders. You have to be very careful that doesn't go through dangerous anastomosis with compromise of cranial nerves, or sometimes we also seen embolic strokes in the anterior posterior circulation.
Yeah, Giuseppe, I've had the same exact experience. We wrote it up and didn't, but sometimes you go to the fistula point and then it gets retrograded to feeders, other arterial feeders that were coming to that point. I think that's what Professor Miyachi was alluding, that it gets to all the networks. I even had one actually go up the anterior spinal artery and into the basilar. So onyx can be very, very, very effective, but in its effectiveness can get into collaterals that you wouldn't see before.
Yeah, we say onyx, the onyx connects the dots, right? Yeah. There are these connections, and sometimes they are so fine that you cannot really see. So it's we are very we should be very cautious. Yeah. But no, it's a great. We have used a lot for. Even for the lateral tentorials over the years, we've had great successes with transarterial onyx. Is definitely has been a major advance in our treatment of dura fistulas.
Thank you very much, Professor, for those comments and discussion. Anybody has any other question or a doubt? Or we have 3 speakers today. Can go ahead with that. May I request Professor Fawad Pirzad to make his comments about Professor Lonzino's presentation? Professor Fawad.
Hello. Thank you very much, Professor Lonzino, for this such an excellent presentation. Thank you very much, and it was very useful. And thank you for comments, Professor Ali Aziz Sultan. And I like to for you to imagine we do basic neurosurgery, but traditional and classic instruments and equipment in Afghanistan. Fortunately, we have modern imaging like CT scan and MRI, but unfortunately, we have a neuroradiolog to read the MRI and CT scan. And for this, the diagnostic clinics which are private, not public or government MRI diagnostic or CT or angiography, they send it for results reports abroad, but they are for trading purpose, for business, and no good reports. And unfortunately, when they diagnose a fistula, but no way for treatment in Afghanistan. We haven't endovascular, no radiosurgery, and just we do treatment conservatively, and we hope and seeking your help for training of Afghan young neurosurgeons for endovascular, and also the other big issue is neuroradiology. And we need also training of our radiolog for neuroradiology as well. And we hope someday we also do some advanced neurosurgery as you are doing now. We are optimistic for the future. Thank you very much.
Thank you.
Thank you. Thank you very much, Professor Pawar. Dr. Lonzino, you want to say anything?
No, I want to thank for the invitation, and it's if there is anything I can do, the colleague in Afghanistan, feel free to reach out to nowadays we can communicate at the distance and work together. So
Professor Fawaz, with that, I'll share Professor Lonzino's email with you, and please try to communicate with him. Maybe you can send a few of your best students for endovascular training there. I'm sure Mayo Clinic is one of the best centers to have a training. So
Okay.
I think we've got 3 speakers today, so sorry to interrupt for that beautiful discussion, but I think we'll have to move on. And since we are into endovascular, we'll continue the endovascular session with Professor Shigeru Miyachi. I would request Professor Shi Jifeng to be with us. We'll follow up your talk after Professor Miyachi's talk. Is that okay, Professor Jifeng?
Yes, yes.
Okay,
Thanks.
okay. Sure, thank you then. So allow me to have a very small introduction of Professor Shigeru Miyachi. He is the chairman and professor of neurological surgery, and also a director and professor endovascular therapy at Aichi Medical University. He is the president of Japanese Society of Endovascular Treatment, and is also president of Asian Australasian Federation of Intervention Therapeutic Neuroradiology. So he's going to talk with us about challenges that we have with the endovascular approach for the difficult cerebral aneurysm. So I request Professor Shigeru Miyachi to share his screen and start his presentation, please.
So, is it okay? So
Yes,
share?
we can see it, Professor. Please go ahead.
Okay. Thank you for your invitation, Dr. Chairman and Dr. Professor Yoko Kato, to this very nice seminar. So I will talk about the challenge with endovascular approach for difficult cerebral aneurysm. This is my CY. And I will briefly introduce my university. That is the center of Japan. And this is close to the Nagoya city. And between the Nagoya and the Toyota city. Toyota is a vehicle maker. And so now we have about 900 beds. And last year we have 800 operations surgery, and including 240 endovascular approach. And so our policy is less invasive neurosurgery, and we have so some parts of neurosurgeons, spinal surgery, and so functional neurosurgery, and also endoscopic neurosurgery and keyhole surgery, and a neuroendovascular therapy center. So I introduce the treatment options of the cerebral aneurysm. As you know, the clipping and coiling is the major options for the aneurysm. But as far as in Japan, the clipping is decreased year by year, and now the 2022, the coiling and clipping is 50-50, the same rates, same percentage. Not only the ruptured one, but unruptured one. In my own historical review, so I have the 1,046, 500 unruptured aneurysms these 20 years. And I divided 4 stages by 5 years. The first stage is a sufficient perfect rhinopal course. The second stage, 2006 to 2009, is a perioperative antiparietal management is constructed. And in the third stage, 2010 to 2014, the stent-assisted technique is introduced. And in the fourth stage, it's to now, in the application of flow diverter. This is a very big breakthrough. And the location of an aneurysm is in the first stage, about 15 to 20 years ago, the anterior circulation aneurysm is about 2/3 of all the aneurysm. But now, in the fourth stage, the anterior circulation aneurysm is about 80%. That is not posterior circulation is decreased, but anterior circulation is has an indication for the endovascular approach. And the embolization methods is the first stage. In the first stage is mainly is a simple method, but in the fourth stage is 30% is treated in the stent-assisted technique, and half of these is treated by flow diverter. And the complication rate is gradually decreased. And now the symptomatic complication is less than 2%, and major complication is less than 1%. On considering the factors of such a better results is mainly these 4: improvement of imaging, perioperative antiparietal management. That's new. Now we have adapted 2 antiparietal agents from the two weeks ago from the operation, and then we continue such a dual antiparietal about 3 or 6 months after the operation. And also improvement the devices and the strategy and the technology. So it is so year by year, that is a very nice improvement. So this is my topic today, and the challenge within the vascular approach for large giant and blood blister-like aneurysm and MCA aneurysm. And finally, I introduced the robotics for the aneurysm in the vascular treatment. First, large giant. As you know, the flow diverting stent is a very nice device for the giant aneurysms, particularly in the carotid cavernous aneurysms. And now we use a pipeline thread or surface for such a big aneurysm. For example, this is a 40-year male, big, about 4 centimeter aneurysm, and only one flow diverter pipeline. And you can see the eclipse sign that is suggesting stagnation of the flow, intra-aneurysmal flow. And just after the operation, there's still remaining the opacification of the aneurysm. But 6 months later, that is completely occluded, and aneurysm shrinked. This is another case of the big carotid cavernous aneurysm. This is so big, and we cannot confirm the cause of the inside the aneurysm, the entry and the the outside. So we have 5 pipeline was placed inside the aneurysm like this. This is a telescoping stent, but it is successfully occluded, and the patient chromotor sign decreased, disappeared. And flow diversion versus conventional treatment. There's a lot of papers. And of course, carotid vessel destruction, that is meaning the trapping with or without bypass. This is a good treatment result, but this is a very invasive. So, such a pipeline or a flow diverter, it's a good result, and more than 80% of the complete occlusion. We have the same result, and this is our papers. But flow diverter is not yeah, it is nice result, but some cases have delayed complications. Very severe complication is a delayed rupture. That is particularly in the intracranial, for example, ophthalmic and large aneurysms. After the pipeline, that is ruptures 6 or 7, 1 or 2 months later. That even though that is completely occluded, it looks completely occluded, but a rupture. I think that is a promote thrombosis, very aggressive thrombosis may become the change of the intra-aneurysmal flow and then rupture. So in such a case, paraclinoid aneurysms, we use the coils. So coils placed in advance and then put a stent. And also have a risk, we have a risk of delayed instant thrombosis and branch occlusion. So we have to strictly manage patients with dual antiparietal agents more than 6 months. And also some cases have a recurrence. That is also unrelieved problems. So next topic is blood blister-like aneurysm. Of course, that is a good indication, or first choice indication is a trapping or the subselective clipping. And usually that is a very, very fragile aneurysm. So the IC trapping plus ECIC bypass is the main operation. But we challenge the stenting for this very severe aneurysm, very difficult aneurysm. This is a case of a young 48-year-old female, and you can see the IC anterior wall aneurysm, very small one. We put the LV stent. This is a braided stent, and it's a very small mesh. And we only put a stent. And you can see the very tightly, so like a crash. So it is this mesh is very, very close, and this is covered the neck of the aneurysm. About 1 week, 10 days later, the aneurysm is decreased and then completely occluded. But this stent is only assisted stent, coil stenting, stent for coiling. So that the mesh is of course the more tighter than the other stent, the other assisted stent. But for example, in this case, very tiny aneurysm here. We only put the stent here, but day 2, day 13, still remaining an aneurysm. So we put overlap the other stent, and the third stent still remaining. So they 4 months later, still remaining and a little bit increased. So we put the coil in the neck, and then that is a jack up to the other stent. And so that is sandwich. The coil is sandwich to the former stent and this present stent. And finally, that is successfully occluded. In such a case, that is a stent mesh is not so enough to occlude the entry of the aneurysm. So this is a recent case. We use a flow diverter for this blood blister-like aneurysm. It's a very severe grade 5 SAH. You can see here is a blood blister-like aneurysm here. And then we put the flow diverter pipeline, 2 pipelines overlapped here. That is, and so 1 month later, that is completely occluded. Sorry. Yeah, completely occluded. So I don't say the flow diverter is perfect, but this is a chance for the occlusion of this BBA with the very smallest invasive technique. This is a paper of the treatment for the blood blister-like aneurysm using a stent endovascular approach. So of course, the surgical complication, the operation, a procedure-related complication is surgical is larger than the endovascular. And just a paper, of course, a higher occlusion rate in such a trapping with a bypass than the flow diverter cases. Complete occlusion rate is very high, but a higher occlusion by a higher retributive rate in flow diverter than trapping. Of course, that's so. So that is not a perfect treatment, but particularly in this very high-grade SAH patients, we can consider such a stenting, flow diverter stenting for such a blood BBA. Another challenge, MCA is of course this is the first choice. In our university, the MCA is the first choice is a surgical treatment, clipping. But and outcome is better in embolization group, and recurrence is higher in embolization group. This is some papers. In some papers, that is the same result. But and meta-analysis, of course, also the clipping is better than coiling in the complete occlusion rate and favorable outcome. And but the surgical clipping remains higher, safe and efficacious, and endovascular treatment improves in efficacy and safety. It results in lower rates of conclusion. But in some cases, particularly in unruptured MCA aneurysms, patient does not request the craniotomy, and sometimes we must do the embolization for the MCA aneurysm. But particularly, we use a stent-assisted technique. For example, this one, this is unruptured aneurysm with a 55 years female. You can see the superior branch is directly originating from the neck of the aneurysm. So we put the stent here and then occlusion with cord. In such a very difficult aneurysm, very large aneurysm, you can see the no neck and a very broad neck. And this branch is so directly branched from here. And this branch is also, this small branch is also originating from the aneurysm. So we put the stent here, and then we use a double catheter technique here to protect these two branches. And this is a recent case, and we use two catheters and 2 compartments, and this is the final view. And you can see the 2 branches is preserved and completely occlusion of the dome of the aneurysm. And what is the situation to select the embolization for MCA aneurysm? The reason, the main reason is the patient desire, but high risk general condition, and also one of the multiple ones. The patient does not like the bilateral craniotomy. So the one side is scraping, but the other side is maybe they will desire the embolization. And also, so that is the MCA Miller aneurysm. In such a case, the patient will request both aneurysm one time, no craniotomy. For example, this one, here is an aneurysm. It's a very complicated shape. And we use a double catheter technique and so successfully occluded the aneurysm, and this branch is preserved. The other side is here, also the very complicated shape, and here is a very similar shape. And we preserve the microcatheter and occluded the aneurysm. This is only 3 hours operation, but in the both sides. The other one is an MCA plus pike aneurysm. Here is an MCA aneurysm. This is very small. We put the stent and the stent-assisted coiling. This is a pike aneurysm, and also we put the coiling here. Another one is the problem of the general condition. Here is under the chemotherapy for renal cancer. So he does not like so major craniotomy. So we put the stent coils with a double catheter technique. And here is successfully occluded. And he could continue the chemotherapy after the operation. So early. And this is our result. And of course, the complication, M2, particularly in this occlusive complication in 2 patients. This is the example. Here is a stent assisted, and the coil is placed. And that is just after the operation. It's very fine, and it looks so perfect. But 10 days later, she has a mild hemolysis, and so emergent angiogram shows this occlusion of the stent. We cannot recanalize now, and still infections in the temporal area. So, yeah, MCA aneurysm is a very, very difficult. It's mostly very difficult because the branching, direct branching pattern is seen, and particularly in the unruptured aneurysms. So we must use a stent, but so in the other side, we must care such an instant thrombosis, delayed instant thrombosis. But we have now a lot of devices, particularly in these 2 years. We got a very nice stent. This is a pulse rider stent. You can see here that is push up the coil into the aneurysm, and that is supports it here. And you see the very, very big, difficult MCA aneurysm, no neck. And we put this parasite here. This is across the neck, and then coiling here. Of course, she is very elder patient, so we select embolization in this. It's a complicated technique. So this is a conclusion of my in our institute. The angiographic result embolization becomes better improves due to the improvement of technique and devices. The endovascular treatment can be applied for the high-risk patients, and it's including blood blister-like aneurysm and MC aneurysms. So lastly, I'll introduce briefly the robotics. As you know, the Da Vinci is very popular for the abdominal endoscopic surgery. And in our field, in our endovascular field, this robotic technique will protect the surgeons from the radiation exposures and also from the infections. And the final goal of the robotics is to conduct the remote experimental telesurgery. This is our full system. Here is a microcatheter robot. This is a guide wire control robot. And also our robot has a power sensor. This is this indicates the resistance of the micro guide wire. And this is the experimental study of the angio room. I control the control machine in the control room, and here is a robot on the angiography table. This sound is indicates resistance. The higher tone is a high resistance. So do, re, mi, fa, sol. And we listen to this sound. And if the sound is very high, this is a very high risk of the penetration of the vessel. So we stop the procedure immediately. Yeah, and we have an experiment for the remote surgery. Here is the other room, separated room, and this is an angiography room. This is a vascular model, and this is a robots. Only this one, no human in the angio room. And we control the manipulation in this separated room, and then slave robot will operate. And I tried to embolize the coiling in this vascular robot. And so, yeah. I saw the same monitor in the angiography room, and then place a coil. And of course, we control the coil and as well as the microcatheter position. And this is not good, so we press it again. And finally, successfully treated. And also, now we use two robots using a double catheter technique. Here, we control the two robots simultaneously. And also, this is stent-assisted coiling, stenting and coiling. The two robots on the angiography room. And so, still, and such an endovascular robot is already clinically applied in the cardiac team. And this is a Corpus GRS system. And this is for the PCI system. And that is applied in some more than 2,000 patients in USA and maybe more than 100 patients in Japan in the cardiac field. And also the Professor Pereira in Toronto, that is he applied this machine to the coiling for the basilar aneurysm. This is a paper. But still remaining a lot of the problem, particularly time lag of reproduction. That is because the control of this joystick, and then that is transduced to the slave robot about the 0.7 second delay. So it is so not a quick communication, and that is the risk of the delay. That is penetration of the aneurysm. But 5G system, that is so dramatically improved this time lag, about 0.1 second. That is an acceptable level. So now we continue the experiment for using this system. So such a robotics is so very nice, but still so early for the clinical application. But I think in the near future, that is a very nice system to realize telescopic surgery, telesurgery, particularly in the remote area. Remote area without the expert of the endovascular surgeons. Okay, so thank you for your attention. This is our challenge, but it's not so recommended. But this is our challenge. Thank you for your attention.
Thank you.
Thank you very much, Professor. I must say, learning about robotic endovascular neurosurgery, very latest thing, and thank you for sharing that knowledge with us. I would request Professor Ali Aziz Sultan to make a comment about Professor Piatri's presentation. Professor Ali.
Again, I think this is the prime example, not only the excellence that we hear about and now are privileged to see from Japanese neurosurgeons, but also speaks to the innovative, pioneering spirit of neurosurgeons. Professor Miyachi's pushing the field in every direction, whether it's going after MCA aneurysms, which is still, in my opinion, a open surgical technique, or trying to expand the field with robotics, developing their own robotics, trying dual catheter techniques, just excellent pioneering, innovative work, which will eventually solve, I believe, some of the issues that Professor Kato is trying to address. These remote surgeries, helping with education, potentially remotely supporting physicians in other areas, patients in different, even in Boston, there's not endovascular neurosurgeons in some of the places like Cape Cod. And so these centers that are teaching academic centers will extend their reach like they are right now through Zoom, but hopefully with robotics. So this is just beautiful work, Professor Miyachi, and a fine example of Japanese neurosurgery. I have a question for you. I have also, a number of us have really tried to address these these blister aneurysms, these dorsal wall aneurysms that you're doing, and I've done clipping, which is disastrous sometimes, as you know, to coiling with recurrence, to onyx when there was onyx for aneurysm, onyx 500, to double flow diverters, to stent jacking. And everything comes short. The closest thing that comes to it has been the flow diverters. And the last one I remember, I put one, and then it grew, and then I put another one, but it's a scary time while you're waiting. How do you decide how many flow diverters, Professor Miyachi? And do you think trapping plus bypass is still the only real solution for these blister aneurysms?
Yeah, flow diverter is very challenging and not. This is a very final solution, and we first of course we consider the trapping with bypass, but it's a very bad condition, the patient, and that is a very angry brain, and this is a very difficult. So of course, after the flow diverter, we must add the load the antiplatelet. So that is so induce the rupture. So it is not a perfect way, but we can do it. So of course, under the enough consent of the patient or patient family, and I think this is a final solution. But I as I said, some papers have a good result. So
yeah.
I think if this pipeline, 2 or 3 pipelines will make good result. I don't know, but I hope so.
Yeah. Well, one quick other question, and then I'll pass it on. The one case where you did the stent, the coil jacking technique.
Yeah.
Were you able to get through the first stent and put the coils inside the aneurysm, or did you put it outside in between 2 stents to sandwich the entrance into the aneurysm? I didn't understand that.
Yes. Yeah. In some cases, that is only 3 cases, but we have coiling then stenting in the first step. That is okay, and that at that case, we hoped we expected the spontaneous thrombosis of the overlapped stent, but finally we put the coil, so attach the stent, it's a former stent, then the other catheter is placed the stent inside the former stent, and then jack up, and that's it. It's a very difficult technique. The coil is shifted to in the pulsatile, so that's a very lucky case. Yeah,
very cool.
So we must put the coil in the first stage, but particularly in the first coil, we rupture the blister rack. That is a very disaster. So we don't like it.
Very cool. Thank you. Any other comments or questions? Achin.
Dr. Miyachi, thank you very much. Thank you so much. Even a very short notice. Your lecture was excellent as always, and I think already the Ali that he asked you, because I was wondering the treatment of the blister-like aneurysm. Of course, the occlusion plus high flow bypass is one of the best choice, but I think sometimes great 4-5 is sometimes quite difficult because a very angry brain. So, and also the blister-like aneurysm is immediate, the growing, the very dangerous one. So we don't have enough time to do the sometimes open surgery. Maybe Shubin and he can you can have some comment about the blister-like aneurysm. How do you think? How do you treat?
For me?
Shubin.
Dr. Shubin, your voice is muted. Can you unmute it?
Shubin,
you're muted, Professor.
Please.
You'll have to unmute yourself. you're not audible. You'll have to unmute Professor Bingsu. We can't hear you. You'll have to unmute. Dr. Raja or Dr. Ben, you are the host. Can you try to unmute them?
Ben, please.
Yes, I am asking Professor Xu to unmute himself, but seems we are waiting for his response.
Ben, please,
Hi, Xu主任.
Ben, you can ask a question.
Okay.
Yeah, okay.
Yeah, okay.
So I can ask the question or not? Session?
Hi, 徐斌主任，听得到吗？徐斌主任。
Yeah.
Yeah, now you're audible. Please.
Hello. Hello, Professor Xu.
Hi. Nice to meet you. Because I have another webinar. So
okay.
Sorry.
They have some comment.
Actually, I missed the presentation. It's about talking about the high flow bypass to treat the ruptured MCA joint aneurysms.
No. Blister-like aneurysm. Blister-like aneurysm. Yes.
Okay.
How do you treat that?
Mm-hmm.
Yes.
Yeah. Normally, I will use bypass. Yes. Sometimes we will try to wrapping it. Sometimes I use some cotton to wrap the ICA. Then add a clip to wrap the ICA.
Mm-hmm.
It's also work, yeah. It's much simpler than bypass.
Mm-hmm. Sometimes when we think about vasospasm, so the wrap clip is sometimes the stenosis of the main trunk itself.
Yes.
So they'll be very careful.
Yeah, if you do the bypass, I think it's helpful.
Thanks. Ben?
Thank you, Professor. Ben, can you ask it down?
Yes. Hello, Professor. And I'm Ben from Hong Kong. So thank you for a great presentation and very encouraging to see your result on your robotics prototype. So my question is that, first of all, may I ask for the MC aneurysm that you have experienced with some complication, those with MC occlusion. How would you manage those patients? Would you do endovascular thrombectomy immediately to recanalize the stent? My second question is about for those large vertebropapillar junction with dolichoectasia. How many full directors would you put inside? So thank you very much.
Yeah, about MCA aneurysm, the one case where we try to recanalize use the urokinase, and that is so successfully recanalized. But in a case as shown, that was already a complete stroke, so we don't like to recanalize it. But of course, in the acute occlusion, we try to recanalize to thrombectomy or the other stent. That is the same situation in many cases. And the second question is dolichoectasia. Dolichoectasia.
Yeah. Those sometimes have some giant aneurysm, so it's difficult for bypass. So maybe the solution is maybe from the stent by the full director. Any techniques that you can share with me about, for example, how many stents, how to prevent the thrombosis of those branches of the basilar tree?
Yeah, it's a big issue, and that is very controversial and not no conclusion. And in my opinion, the dolichoectasia, particularly in the basilar trunk, is no indication of the flow diverter, because the dolichoectasia has a lot of perforators that is directly branching from the dome. So if we put a pipeline or flow diverter, if the dolichoectasia is completely thrombosed, that is suggest sacrificing the branches. So very big complication. So we don't like so flow diverter for the dolichoectasia. So I think that is still big problem even in the surgical procedure, but surgical treatment within bypass trapping is so maybe the fast treatment. I think.
Thank you very much, Professor, and thank you for your great presentation.
Thank you very much.
Thank you very much, Dr. Ben. So, do you have any other comment or any question? If not, I would request Professor Miyachi to be with us, and we'll go ahead with our third presentation. So, may I quickly invite and introduce Professor Shi Jifeng. Shi Jifeng is a medical student of Shanghai Medical College and completed residency training in neurosurgery at Kaohsiung under the direct supervision of academician Professor Zhao Lianfu. His special interests are glioma surgery, neuro-oncology, and keyhole minimally invasive microsurgery. He is at the moment associate professor at National Center for Neurological Disorders at the Department of Neurosurgery, Huashan Hospital, Fudan University, Shanghai, China. And today he's going to talk with us about supraorbital approach keyhole surgery for anterior skull-base many tumors. May I request Professor Shi Jifeng to please start his presentation and share his screen.
Okay, thanks for the introduction of Dr. Sachin. First, I want to share my PowerPoint. Can you see my PowerPoint?
Yes.
Okay. So firstly, I want to thank that the invitation from Professor Yuko Kato, Professor Liu Busun, and Professor Shibing's invitation to this webinars, and it's always very happy and honored to participate in ACNS webinar course. So today's my topic is about the superorbital keyhole approach for anterior skull-base meningiomas. And this topic is not a new topic. And this surgical approach has a very long history. But as a young neurosurgeon, I started to learn the supraorbital keyhole surgery from the 2019 and started to do the surgery via this approach from the 2020s. So today I want to share some of my experience, and I would like to have comments from all the very famous professors online. So for the anterior skull-base meningiomas, the occurrence in annual incidence is about 13 per 100 persons. And the major clinical manifestation for the patient is about the headache because of the higher cerebral pressures, and the tumor invade optical nerve or the olfactory nerve that will cause patient have the visual impairment and anosmia or hyposmia. So for the epidemiology of the anterior skull-base meningioma, it accounts for about 6% to 12% of all meningiomas. And the most of this kind of meningioma belongs to benign tumor. That means WHO grade 1s. So how to resect this kind of tumor? It's not so difficult for many neurosurgeons, and they have a lot of choice. In the past, we would like to use the traditional approaches like the coronal approaches or Terional approaches, but recently, more neurosurgeons prefer to resect this kind of tumor that view more mini-invasive approach, just like supraorbital keyhole, mini-Terional keyhole, endoscopic assisted transnasal approaches. So today's my topic is about the supraorbital keyhole approach. So why I am so keen on the supra keyhole surgery is I have a small story with Professor Yuko Kato. I remember that in 2018, at that time I was only a resident, and we have a keyhole, conferences in China, Suzhou, and Professor Yuko Kato is the chairman of that conferences. And that conferences, I'm so impressed by his keyhole surgery for the aneurysm clippings. So from then on, I started to try to learn how to use the keyhole surgery approach to resect the tumors. So that is the differences between keyhole surgery and microsurgeries. It is a very tailored surgeries, not only for neurosurgeon, but for patients. You need to choose what kind of patients that is suitable for keyhole surgery. And another major difference is about you need to resect tumor from inside other than from outside, because keyhole is a very small corridors that that gives space to you to perform the tumor resections. And you should be more patient when you're doing the keyhole surgery. There is no chance for you to have the mistakes. But for keyhole surgery, there is a very important concept is about the more deeper the tumor located, the more wider space you will have to do the manipulations. So this is the consensus paper that published by the Qin Lan from China that on the neurosurgical reviews. And we can see if we use the supraorbital keyhole approaches, we can have a very good visualized exposure of the anterior cranial fossa, and we can see the optical nerve, see the olfactory circles, and we also can see the interpedancular systems. So we can do a lot of surgeries via these surgical approaches. And the potential advantages of the keyhole, supraorbital keyhole approaches, there are a lot of papers that make comparison between the traditional craniotomy and the endoscopic transnasal surgeries. So I don't want to talk about more on this point, because many surgeons, they have their own criteria on how to choose the surgical approaches. So from the 2021, I started to do the anterior cranial base managiomal resection via supraorbital keyhole approach myself. So I just do a small summarize for all the cases I have carried out. There are 61 cases, and more cases are the WHO grade 1 cases. So just make a strategy for how I do these surgeries. So I separate these surgeries into 3 types. We call it the anterior type, central type, and the posterior type. So for the anterior type, the most meningiomas are located and olfactory groove. And for the central type, the tumor based in the sphenoid plateau and the tuberculum cells. And for the posterior type tumors, the tumor may invade located in the diaphragmal cells and invade optic nerve and ACA or ICA. So I will, before we started to do the tumor resection, the very important step is we need to make our incision very beautiful, because this very first step is important. We should notify the clear layers of the skin, subcutaneous, and the frontal muscles. We should not cut them overally. We should separate them. After we separate them, there are no bleeding. So we don't need to use bipolar coagulation. As we know, if we use too much bipolar coagulation, it will do the damage to the skin, and the skin recovery, incision in recovery is poor for some patients. And sometimes we will confront the crest on the anterior cranial base. So we don't need to remove this crest after we remove the bone flap. We need to open the dural and lower the release the CSF and lower the cerebral pressure. Then we go back to the crest of the anterior cranial base, then do the remove. That will do less imagery to the frontal cortex. So I would use several operation cases to demonstrate how I do these three types meningioma resection. The first is anterior type meningiomas. So most of the cases are based on the olfactory grooves. So this kind of tumor is more superficial and more close to the neurosurgeons. So actually, it is not very easy for neurosurgeons to resect this kind of tumor through the keyhole approaches because they are too close. So we should try to rotate the patient's head for more angles that we can make whole exposure of tumors. And for this kind of tumor, we need to do the lumbar puncture for CSF drainage because we don't have space left to us to release the CSF. We just need the lumbar puncture to lower the blood pressure and to retract the frontal lobes. For the incisions, we need to extend the incisions to the middle lines. And sometimes we need to surpass the superorbital foramen. Then we can, it is same as the bone flaps. We need to more get close to the middle lines. So this is the first case is a female case, and there is no special chief complaints. And from the MRI, we can see there is a meningioma located in the anterior cranial base, and it's invade the olfactory grooves. And we can see from the MRI, the most part of tumor is located in the right part. So for these cases, we plan to do the resection from the right superorbital keyhole approaches, and we do the lumbar puncture CSF drainages. And so let me see from these videos. Actually, for the anterior type meningiomas, we cannot see clearly the boundary of the base because some base is on the contralateral anterior cranial base. So we firstly try to do the debarking of the tumors. When we have much more debarking, then we can step by step to stretch out the boundary of the tumor and see the contralateral base boundary. And during these operations, we need to much more carefully about the olfactory nerve protections. For this kind of tumor, no damage to the olfactory nerve is very important. See, we can protect nerve very carefully. And then we do the piecemeal resection. After all, we resect the dura, and we use the bio-dura to reconstruct of the anterior cranial bars. So we can just achieve the Simpson grade 1 tumor resections. And there is no facial edemas, and the olfactory sensation preserved well. The length of stay in hospital only 6 days. It's much shorter time that for patient. If patients have the craniotomy as the traditional approaches, they may stay in the hospital for more than 7 or 8 days. So for the central type meningiomas, the lumbar puncture for CSF drainage is not always, as like I said, because we have some space to release the CSF from the ICA systems. Maybe it's hard to release CSF from the optical, interoptical nerve systems, but we can from here, yes. But for this kind of tumor, because it is a little bit deeper inside, we should carefully about its relationship between the ICA and ACA and the optical nerves. So this is a typical case, that a male case that had it for more than 3 months. And from MRI, we can see the tumor is based and the sphenoid plateau, but for this patient, is very we carefully studied the MRI before the operations. We decided to do the lumbar puncture CSF drainage as well. Why? Because this tumor's major part is on the left side. If we do it from the right side, and there is no space left for us to release the CSF, either from the ICA system or from the interoptical nerve systems. So we decided to do lumbar puncture CSF drainage before the surgeries. Yes, so that's the surgical plan for us to do the tumor resection for this kind of patient. We go through it from the right side. So for this tumor, because it's located more deeper inside, it does not like the anterior type tumors. We can see clearly the base boundary of the tumor. But the strategy for this tumor is quite similar as the anterior type meningioma resection. We first do the intratumoral debarking. When the tumor volume is shrink, then we try to delineate, separate the boundary of the tumor totally. Yeah. So if we go to the posterior part, we should pay more attention to the relationship of the tumor with the ACA. Yeah. That's the most important. Yeah, we can see here, that's most important. We should take care and not to manipulate roughly. We should carefully to separate the boundary of the tumor. And it's the same that when the tumor resect, we will resect the dural of the tumor dural signs, but it's sometimes difficult to resect the whole dural that which tumor invaded. So we will resect the superior layer of the anterior cranial base dural and reconstruct the dural with the biological dural. Yes. So this is a post-operative MRI. We can see the tumor with total resections. And also no facial edema, and the olfactory sensation preserved well, and the length of stay in hospital is 5 days, and the patient recover well after operations. So for the posterior type meningiomas, just like I said previously, that the concept of the superorbital keyhole approach is that the more deeper the tumor located, and the wider the manipulation space is we can get for the neurosurgeons. So for this kind of tumor, actually we don't need to do the lumbar puncture for CSF drainages, and also we should shorten our incisions length. There's no need to suppress superorbital foramen. Just the inside the foramen is okay for this kind of tumors. And sometimes because the corridor is long, sometimes we need to resect the tumor via the assistance of the endoscopy, and that will help us to do try to do the total tumor sections. So this is a female patient, and the patient have the blood visions, and we can see from the vision field defect on the right side. And from CT MRI, we can see there is a tumor located and major and the diaphragmal celli. And there the relationship between the tumor and the ICA and ACA is very close. So we need to pay much caution when we separate the tumor between the vessels. And this is an MR enhancement. So for this kind of tumor, there is quite different for us to do the resection via the anterior or the central type. Although the major part of the tumor is located into the right side, but we don't want to go for it through the right side. Why? Because if we from the right side that there is some tumor that may be located below the right optical nerve, which we cannot see it clearly, that means it is possible that the tumor may residues. So we started from the left side. If we from the left side that we can clearly see that the tumor below the right optical nerves. So this is a tumor resection. And here, why we don't need to do the lumbar puncture, because we can get direct access to the ICA system or the inter-optical nerve systems and release the CSF. After we release the CSF, we retract the frontal lobe by the retractors and exposure tumor and try to resect the tumor as the same we do that first they debug tumor site. And separate the tumor's boundary very carefully when we got the posterior part. We should skip this. Okay. So for this tumor, we use the endoscopic. Why? Because we can see there is some the Dura signs which we cannot see from the microscope. So we use the endoscope and see clearly about this part of the tumor's residues, and then we changed with the microscopic and do the tumor resections, and also we burn the the Dura signs, and then we use the scopic to recheck, and we can see the residual tumor resection, and the Dura signs was burned. Because for this deep inside seated tumors, we cannot do the synchronous 1 resection. We just try to do the synchronous 2 resection. That is okay. And sometimes if the tumor is attached to the ACA, ICA optic nerve very tightly, we do not force to resect tumor totally. Sometimes we need to have tumor residue and do the gamma knife when tumor during the patient follow-up. So this is the pictures that we use the endoscopic, and we can see that from the thickened space, there's a tumor left and the tumor Dura signs, and we can see here. If we do the cases from the transnasal approaches, this part is not available for the transnasal approaches. So after operation, the visual defect, a field defect for this patient is recovered. So this is an MRI for the post-operations, and the tumor is totally resections. And after 3 months of the operations, we can see that the patient has a very good lookings, and it is nearly hardly to see the incision scar on the eyebrow. So sometimes we will meet several complicated or very big anterior cranial meningioma cases, and many patients or many surgeons will ask whether we can do the resection of this tumor through the superorbital keyhole approach. Yes, we have tried several cases, but it's not suitable for all the cases. And like this case, we used this approach to resect all the tumors, and the looking is good for this patient. And then for this very good, very big olfactory groove meningiomas, we also use superorbital keyhole approaches. And for this tumor, we need to combine the techniques of the anterior, central, and posterior type meningiomas to do the resections. But if for these very big tumors, if the cerebral pressure is very high, I recommended that you should do the brain resection, just like we resect some part of the frontal cortex. Then we will have very good exposure of the tumor. It is not forced to protect the cortex to resect these tumors if you use the superorbital keyhole approach. So for the starting for the tumor resection, and it's very important to do the closings. Yeah, it's very important because unlike that the classic craniotomy surgeries, because the incision is in the hair, so there is no obviously signs to we can see the incision. But for the supraorbital keyhole approach, we can see the incision very clearly. So firstly, we need to do to keep the bone flap and the frontal muscle must be anatomically reduced. It's very important. That is very important for good looking for patients. And another very important point I want to mention is about how to handle the frontal sinus. This is important because if we have not closure of the frontal sinus, then a lot of patients will have the frontal sinusitis after the operations. So we can see from my case cohort that for this 16-1 patient, I also do the 104 craniotomies, the classical craniotomies, meningeomal resection at the same period. The gross total resection rate for the two groups is quite similar, but the length of stay in hospital for the patient is much more shorter for keyhole surgery patients. That's why keyhole surgery may have the potential advantages over traditional craniotomy surgeries. But what I want to reiterate is that we should choose the case more carefully. We cannot do this case that whatever we want to do. So to the conclusions that the supraorbital keyhole approach for anterior skull-based meningeomal resection will have a very good clinical outcomes and have very minimal invasives for the patients. And for the three different types of the anterior skull-based meningiomas, that we should tailor the individualized surgical strategies for each patient, including the head position, including the length of the incision, and including whether we should do the CS drainage by lump puncture or not. And also, we should use the endoscopic or not. So the reasonable surgical strategy, the good microsurgery skills, and the intraoperative patience is very important. Unlike the microsurgeries, there is no space for us to make mistakes. So we need to do the surgery very patient for the keyhole approaches. And also we should use some reasonable instruments, and it's very important, and it's the keys to the success. And I remember that the Professor Pranesky that many years ago, he came to our department and demonstrate how to do the keyhole surgeries. And I read this history from the history of our department, and I was very impressed. So to be a young neurosurgeon, I would like to try to learn and to do more keyhole surgeries and for the in mini invasive surgeries. So the closings, I want to share with all of you a poem that written by Edwards, and the title is about the spring is like a perhaps hand. That means that we should handle this case view keyhole surgery very carefully, and we should not destroy any kind of normal tissues or normal structures during our keyhole surgeries. So thanks for your attentions, and I really enjoyed today's symposium, and I learned a lot from the Dr. Lonzino and Dr. Chiachi, and thanks you all.
Thank you very much, Dr. Shi Jifeng, for that wonderful presentation, and very important and very well presented from the point of young neurosurgeon point of view. I would request our chairperson, Professor Ali Aziz Sultan, to make the comments about his presentation and give us some more tips if you have for the young neurosurgeons.
Yeah, that was a beautiful presentation, very concise, beautifully structured, and videos and everything. We used to do some keyhole for vascular when I was just came back from Spetzler, and Nakaji was just finishing at that point. I always found the visualization difficult and almost mobilizing the pathology more than moving your microscope. So instead of moving you yourself, you have to move the lesion, and an aneurysm sometimes that's not the right way to do. But this is beautiful. Can I ask you your opinion on sort of reconstruction of the skull base and the dura and so forth after you've taken out a meningioma that's invaded and you've taken the dural to prevent future issues, when comparing craniotomy versus endoscopic approach versus keyhole in terms of CSF leaks and repair? How do you think about that? And is there a disadvantage to this versus open craniotomy, or is it the sweet spot between endoscopic and open?
Okay, thanks for Professor Santon. And you're right, it is quite tiresome to do a keyhole surgeries sometimes because you need to move from here to there. Even the start and the closing is quickly, but the time for the tumor resection need a lot of time that may be similar to the craniotomy surgeries. And you talk about a very important point that is about the skull-based reconstructions. Yes, sometimes it's more difficult for us to do this if we choose the superorbital approaches, because the space for us to reconstruct the cranial base is very limited, not like the traditional craniotomy approaches. So for me, that in my opinions, maybe not, I don't have a lot of experience that for me, personally, for the anterior and the central parts meningiomas, I would prefer to do the simple grade 1 resection, but we just resect the superficial layer of the dura, not all the layers. And then we use the autologous fascia or to use some artificial durals to do the reconstruction. And I do the follow-up, and it's also good. We don't need to resect all the tumors, all the durals, because if we resect all tumors, it's very hard for us to do the suture or do the reconstructions. Maybe it's not right, and this is my own opinions. Yes.
Thank you. Beautiful presentation. Thank you so much.
Thank you.
Thank you for your honest answer. Thank you for your honest answers. Thank you.
Thank you. Thank you very much, Professor Liazi Sultan. We have Dr. Rihana from Afghanistan. Dr. Rihana, you have a question? Please.
Hello, Assalamu alaikum to everyone.
Then ask your question.
Hello.
Hello. Yes, we can hear you. Please introduce yourself and ask the question.
Assalamu alaikum to everyone. I'm Dr. Rihana from Afghanistan. And first of all, I would like to thank everyone who has conducted this webinar. My question to Dr. Shi is, for some cases, you had done LP before, lumbar puncture before the surgery. And I wanted to ask, isn't there a chance of downward herniation with the patients who have brain tumor and when we do LP? And how do you manage that?
Yes, thanks for your question, the professor. You are right. We always worried about the brain hernia when the brain cerebral pressure is very high when we're doing the lumbar punctures. It's the same situation for the I remember for the aneurysm surgeries, because for some rupture aneurysm, the cerebral pressure is high. Before operation, we also do the lumbar punctures. But for me, I think that the lumbar punctures for the anterior cranial base meningioma is very safe, very safe. For me, actually, in my process, I firstly do the lumbar punctures, then I do the craniotomies. Maybe the time period after the lumbar puncture and when I get access to tumor is about 30 minutes. 30 minutes. So during these short times, there is no, you don't need to worry about the brain hernia. It's much safe. And when you open the durals and release the CSF from the systems, and it will be much safer. And at that time point, you can ask the nurse to close the lumbar punctures for you, and you don't need to have the lumbar puncture at that time. Yeah.
Thank you so much, doctor.
Thanks for your questions.
Okay, thank you very much for that very important question. Any other doubts, Dr. Chen? We have Dr. Chen from China. You want to ask anything?
Yes, thank you for your so much beautiful presentation and high technique. Dr. Mishiachi maybe left. He's left. I'm very exciting when I watch his robot for aneurysm. Yeah, this is a very high technique and very advanced. So I just wondering if he has any research funds or business investigate to support his this work to innovation robot aneurysm new technique. This question is for Professor Mishiachi. Maybe he's left.
Unfortunately, I think Professor Miyachi is not there. Professor Ali Aziz Sultan is there, and also he does both, as far as I know, he does both endovascular and open work. You want to make some comment about Dr. Chen's doubt, Professor, about the robotics in endovascular surgery? What is the way ahead?
I'm sorry, Dr. Chen, the question was, restate the question regarding robotics and research?
Yes, I think robotic research need so much funds. So if Professor Mishiachi has such funds from Japan or somewhere to support his research, as I know, in Boston and Harvard Medical School, they research such robotic device for operation is very advanced work. So do you have any information from Boston about the robot?
Yeah. So the company that's and I don't know if Giuseppe's on here still or not, but there's a company that was born out of here called Correndas, which is now purchased by Siemens, and their research has basically been in models and so forth. This was developed in Waltham in Massachusetts. A lot of the work so far has been in coronary work, in the cardiac world, and the main value proposition right now is that you can do these procedures outside of the angio suite. So the main value right now is not necessarily for patient safety and things like that. It's more that you're saving the practitioner radiation. So that's what, but we all see the potential for the future of this.
Yeah.
You know, and I believe in India, they've done remote surgery from long distances. I think they've done simulation surgery from Boston to San Francisco from one side of or New York to San Francisco from one side of the country to another. I don't think there's a lot of clinical validation. There's carotid stentings is probably the only thing that centers are doing right now as far as the neurospace. But we're moving forward slowly. He showed the first in-human case from Canada in aneurysm. So it's a field that is just being born. So there's not a lot of clinical validation in human. But like I said, I think this is going to, just like Zoom is bringing you to me and me to you and all over, I see a wonderful potential in remote surgery.
Okay, thank you so much.
Thank you.
Thank you so much. And follow Professor Doctor's question before. She mentioned in the aneurysm, some aneurysm, the angle is very tough to use the calling. In case of the aneurysm ruptured, and we have to change open cranial surgery from endoscope surgery. So how to control such a very emergency situation? We have few time to change patient's position and surgery process.
Yeah, I think this is a good question. I think a lot needs to be put into the preparation for that surgery. A real thoughtful consideration into which technique you're going to use and which decision tree. So one of the reasons that neurosurgeons created hybrid rooms, and I remember when we were creating our own room, there was one in Japan that they sent me the pictures and the schematics. And the point of that operating room, that hybrid operating room, was the ability to go back and forth between open surgery and endovascular. I will tell you that happens very, very rarely. You know, usually endovascular complications are managed from an endovascular route, and open surgery complications are managed from an open route. And I'll give you sort of examples of both. So open complication, aneurysm ruptures, you can't get proximal control easily. You can take a balloon and hold it, and we published cases of that. But that's a very rare thing. Usually you can open the neck if it's an ophthalmic or trap and so forth. So usually your solution for complication from open is open. Go to endovascular. Endovascular, you have this, they were asking, I think Ben was asking Professor Miyachi, what do you do when the MCA aneurysm, the coil come back? Okay, so in the beginning of my career, this happened to me a couple of times. Actually, in an MCA, I made a mistake of trying to coil a young lady. You know, all the things that I learned from making bad mistakes. And the coil came and closed the MCA. And I tried and it didn't. So I took the surgery, opened the head, tried to pull the coil out of the dome of the aneurysm, opened the dome of the aneurysm, but it was a disaster. Now I find that when there's coil prolapse or something like that, that you can give antiplatelet intra-arterial agents. You can sometimes put the stent to go and push the coil back in. So this ability to convert from one to the other, theoretically, it's wonderful. And I think there's a space for it. But usually the management of the complication from open, in my experience, is an open solution. And the management for endovascular complication is an endovascular complication. The one thing that you shouldn't do is go back and forth, which was my mistake in that girl that I mentioned. The coils came out, then I said, okay, I'm gonna go with the snare and pull the coil out. Oh, the snare didn't work, I'm gonna do this. Oh, I'm gonna go to CAT scan to see what the perfusion is. Maybe I can let the MCA go. Oh no, now I'm gonna go to open surgery and then take it out. So it was this decision making that wasn't quick, and it was sequential, and that poor lady didn't survive. She had a horrible MCA stroke and a bad on the left side. So point one, I think the solution from endovascular is usually endovascular. 2, solution from open is usually open. And 3, if you're gonna go, You make your decisions quickly.
Okay, you mean the make the decision quickly? What kind of decision? You mean the next step to change it to open cranial?
Yeah,
Very fast,
like
or just try again. Okay.
No, what I mean is because when you're delaying by going from one decision to another decision to another decision, your time clock is going.
Yeah.
Right. So for me, if I say, oh, this coil is coming out into the MCA, let's go quickly to surgery. Not let's try this for 1 hour, then go to CAT scan for 1 hour, then go to open surgery. The brain can't stand all of that time, and the endothelium gets with the coil. So I think it's rare to switch from one to another in my experience. And if you have to, make that decision quick and go. Don't second guess like I did.
Okay. Yes,
you know,
yes.
I still remember that young lady. You know, this has been 10 years now, you know.
Yes, I understand. It's an impressive experience from you. Thank you so much. Very good information for our young neurosurgeon. Thank you so much, teacher.
You.
Thank you.
Thank you. Thank you. Thank you for your question.
Okay. Sashi, I'm finished. I have no more questions.
Thank you.
Thank you very much, Professor Ali and Dr. Chen. Any other question from any panelists? We have Dr. Nicole from Bolivia. Dr. Nicole, are you there? Yes, Dr. Rishad Ahmed. You have any
Can I have one question to Dr. Shi?
Video is on.
Dr.
Yes,
Shi?
yes, Professor.
Thank you very much for a nice presentation. I think it's quite difficult to with keyhole. That's a small craniotomy. So just my question is how you can differentiate the pure endoscopic and or plus microscope plus endoscope. So do you sometimes think about the pure endoscopic procedure for skull-base meningioma?
Yeah, thanks, Professor Kato. First, I want to say that you know that in the year of 2018, that is my first time to see your face by face personally, and that Keyhole conferences. And your question is very good. I always think about that the pure endoscopic or the endoscopic combined the craniotomy via the superorbital keyhole approaches. I just have my two personal opinions about these questions. The first is what I want to say is the most part of the tumor we can visualize. We can have this through the microscope, through the microscopic microsurgeries via the microscopy, and sometimes we need to some angles or some deep location that we cannot see from the microscope. We can use the endoscopic, but I do not recommend the pure endoscopic. The reason is if you use the because the microscopic is the 3D images, but the endoscopic is the 2D images. Sometimes it will be dangerous for you to handle with some vessels or nerves when you use the endoscopics, because you don't have the real virtual feelings that whether you have cut or not, or whether you have reached it or not. Another opinion from me is that if you use the pure endoscopic, you should very carefully about the areas where endoscopic cannot see, especially for the posterior part, because endoscopic can only see the anterior part. But the posterior part is the missing area for the endoscopic. Sometimes during the operation, you don't have idea that whether your Caesar or the sucker or the bipolar you used is damaged some brain tissue, vessels, or nerves that enter the posterior part of the endoscopic. And sometimes you can see that the bleeding is from the distal area and to the area of that you're visualized by the endoscopic. So I think it is much dangerous. And the optimal strategy is to combine the microscopic and the endoscopic. But that's my own opinion. Maybe it's not right, just for your conference. Thank you for your questions.
Thank you. Very clear. Thank you very much. Sachin?
Thank you very much. Do we have any other question or doubt before we conclude the webinar? So if not, I think this is the time. We've had two excellent sessions on the endovascular neurosurgery and beautiful presentation by Dr. Schwingbaum, minimally invasive skull-based neurosurgery. I would request Professor Yoko Kato to say a final concluding remark, and then I'll make the announcement for our next webinar and our ACNS Congress. Professor Yoko Kato?
Okay. So maybe before me, maybe Dr. Awad, you want to say something? Please.
Okay, thank you very much. Thank you, Professor Yoko Kato and Dr. Sachin, Professor Ali. And it was a nice presentation. This is also Professor Miyachi and Zifeng Shi. Excellent presentation. Thank you very much. We learned a lot of, and we are hopeful that one day we got this advanced technology and doing best operation for our needed patients. But your support and your kindness and humanity. Thank you very much. Arigato gozaimasu.
Yeah, arigato. So maybe Dr. Ali, just one word.
Oh, Professor Kato, thank you. My beard is getting white, and maybe I'm becoming more of a philosopher than a surgeon. I will just say just one thing for the younger people, maybe a couple of words. I think to be a neurosurgeon, you select yourself, and you select yourself very young because of discipline and dedication, because it takes such a long time. And with that dedication and discipline and practice for year after year after year, you become a very, very, very fine machine, right? And not only a machine, you become a leader, you become an expert in something, right? And with that expertise of all the hard work that you put in, you can start to innovate and discover new things and take the first step to pushing. You saw Miyachi, you saw Lonzino, you saw Bang. These people have practiced and dedicated their lives. I think with this comes the ability to really, 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 really help people. And I will tell you that I believe in Afghanistan and Bolivia, in Myanmar, and these other places, the ability for neurosurgical leaders to help lots of people, even if it's not under neurosurgery, even it's profound. I think neurosurgeons are the beacons of light within the medical society. And medical society is one of the pillars of helping civilization, helping the country, helping the people. So whatever you're doing, wherever you are in training, whatever country that you're from, I think as a neurosurgeon and the discipline and the beauty and the privilege that we have in the field, you can make profound changes. Just stick with it. It's a wonderful field. Thank you, Professor Kato. Thank you.
Thank you, Ali. So Shubin, you want to say something?
Okay. Actually, Professor Ali's comments is very important, and I totally agree with him. Professor Zhifeng is a very outstanding young neurosurgeon in our department. I'm very proud he can present his nice work to you. Yeah, thank you.
Thank you
Thanks,
very much.
Professor Shi. Thanks.
How about you want to say something? Please.
Yes, thank you. I would like to draw your attention and like to say you that in the near soon we have Afghanistan neurosurgery grand round, and we have a lot of presentation, and also we have a plan for presentation and for ACNS, YNS to deliver and present our achievement with your support with Professor Ali and all colleagues all around the world and WFNS Foundation. That's we achieved a lot of things during your support, and we would like to have a near soon presentation for our update neurosurgery and reports for from Afghanistan for you, and we would like to also say again thank you for your support. And also I think Dr. Rayhana Ghaffari also have planned for presentation about women in neurosurgery in Afghanistan as well. Thank you. Arigato.
Arigato. Thank you very much. So maybe I think the Nicole, you join now. So please.
Good morning.
Onward. Yeah, good morning.
Thank you. Thank you, Dr. Cato. Good morning. Let me introduce myself. I'm Nicole Fuentes. I'm a fifth-year medical student from Bolivia, and I am very interested in pursuing neurosurgery as a residency in the future. And I really feel inspired by hearing all of you talk about the most select topics of neurosurgery. And as our presenter was saying, Dr. Mura also uses the keyhole doctrine in his surgeries. So I think it's a very interesting topic, and that we have to learn and that we have to know when to do it and how to do it. So I really feel inspired. I really congratulate all of you because these amazing sessions help us to get more involved towards the residency and towards the specialty. So I really congratulate you all and thank you for letting me introduce myself. And also wanted to notice that Dr. Ali's word really touched me when he said that we select ourselves. I really felt that. So thank you, doctors, and I am very glad to be here. Thank you.
Thank you very much. Thank you, Nicole. So maybe you can invite all of us for the seminar, please, in the future. So thank you very much for all the very high level, the lectures. We learned a lot, almost 3 hours, I think. And also, I think the current younger doctor is very lucky because you can do both the very classical opening surgery and also the very latest high technique the surgery. But I think in the near future, I think sometimes you skip the first. You start the endovascular, or just you start from the endoscopic procedure. So the totally different from the classical, the opening, the treatment, I think. So I think a current YNS is very, very lucky, you see. But anyway, thank you very much for your long lasting and the seminar. We had a very good time, especially Ali. Thank you very much for the lead of this the seminar. Thank you very much.
Thank you very much. So thank you very much, everyone. I understand, Professor Yoko Kato, it's the responsibility of the next generation to take this high-edge cutting technology ahead. The robotics in neurosurgery and minimally invasive neurosurgery is the future. And we assure you this next generation, the young neurosurgeons, will take this responsibility ahead and take the neurosurgery at a different level. So we had a wonderful webinar. Allow me to make 2 announcements. So our next webinar is on next webinar is on 14th of August, and we'll have Professor Atul Goel as a guest speaker who will be talking about evolving concepts in craniovertebral junction and spine surgery. And a YNS speaker will be from Saudi Arabia, the YNS member Ahmed Al-Hamari. Another announcement is about our ACNS Congress. Yes. ACNS Congress will be held in Shanghai on 20th October, and Professor Bing Zhu is the organizing president for that. I request all of you, the young neurosurgeon and all the faculties today available, please kindly encourage your young neurosurgeon to send their abstract. We are formalizing our scientific program by the end of this month. Send their abstract. We have a special session for the young neurosurgeon and few awards for the young neurosurgeons also. So please kindly participate. Thank you very much.
Maybe Shavin, you want to say something about your Congress?
Yes, actually we have different sessions, including the developing countries session, like Afghanistan. We can invite Dr. Ahmed, like from Afghanistan, and they can present their conditions, and maybe they can ask for some help from ACNS, and we can give them some help. Yeah, and we also have some young neurosurgeon session. Actually, maybe one day for young neurosurgeon session. If the schedule is tight, we can make the time longer. So Sachin, you can just prepare the session.
Sure.
Yeah, and we can give you enough time.
Sure, thank you. I'll be behind it, Professor. I'll try to arrange as much as young neurosurgeon, the enthusiastic young neurosurgeon possible. I'm sure they'll be enthusiastic to participate after a long break of COVID. So sure, there'll be a great Congress.
Thank you.
Thank you. Thanks so much. Okay.